Hi. So I actually, just a quick show of hands before I kick off. Who here is comfortable in doing slit lamp examination of the back of the eye? Am I talking to the wrong crowd? That's. What about indirect ophthalmoscopy and direct ophthalmoscopy? Okay, fine. So those are the kind of topics I'd like to cover. So I'm Chrishan Gunasekera, I'm an HEE fellow as well for the Ophthalmic Practitioner Training Program and work in Southend at the moment. So the OPT has put together curriculum, as you guys know, and at level 1, 2, and 3 for the CA10 component of your syllabus. This talk will be going over how to perform binocular examination using a slit lamp and various lenses, and how to care for the slit lamp and use diagnostic contact lenses in order to get the best view possible, along with using all the different kinds of knobs and wheels and techniques to best optimize your view of the back of an eye. It does go from level 1 to 3. I'm not going to talk anything about the real pathology that you'll need to look at textbooks and clinical experience. This is just about how do you improve your view and see what you need to see. So I'll talk a bit about direct fundoscopy, slit lamp examination, and indirect fundoscopy. So essentially, fundoscopy is just a magnified red reflex. So those cameras in the 80s and 90s, when they took a flash and somebody had red eyes, if you actually put a lens in front of that red eye, you would see their retina in a huge amount of detail. So it's not just the red reflex is your retina in detail. It just needs that right kind of focus. And anyone know who this chap is? I'll tell you guys. He's Herman van Helmont. So in 1851, he invented the first ophthalmoscope where you use candlelight and a mirror, sorry, a piece of glass rather, that will mean that there's parallel rays of light that are hitting the retina and then coming back through a viewing point. And from that moment onwards, we've been able to see retinal disease in real time, in real life, and it's just been an explosion since then in terms of what we can view. So this is essentially how still a direct ophthalmoscope still works. There's a little pane of glass that you're able to look through, and the glass is reflecting the light directly into the retina, and you're getting a direct view back, and that is your red reflex. And most of them have a red filter. You could vary the spot sizes to try and optimize your view, and a cobalt blue as well. And it's not really commonly performed because it's really, really magnified. And in most of ophthalmology, we actually want to see a much wider field of view, particularly in retina, but it's still useful for examining the optic nerve in detail, or for primary care when they're trying to refer patients in with swollen discs. So because there's no lens, it is direct ophthalmoscopy. The image that you're seeing is the right way up. So the optic nerve at the top is as you'd expect, and the bottom is as you'd expect. It's not flipped around like in the lenses, but because it's only with one eye, you don't get a 3D view of the back of the eye, which has proven to be so useful as time's gone on. And actually, you do have to get quite close to somebody's face. The more you zoom in someone's eye, the wider the field of view that you'll get. So that's my number one tip for direct fundoscopy. The closer you are to somebody's eye, the more field of view that you'll get of the retina. So this is a video of me doing this with just an iPhone. You can do direct fundoscopy, demonstrating that actually when I'm further away, look how magnified that optic nerve is. And then the closer I get, the more field of view that you're able to see. So try not to overcomplicate the slit lamp, because all it is a microscope and a light source. Not rocket science. First things first is always make sure that you've got the right interpupillary distance set up and your prescription is on correctly. You can have different slit lamps, so make sure you know how to magnify to the varying amounts that you need to. And make sure you're comfortable with the filters at the top of the slit lamp. So this one here, it's a heat absorbing filter, but there's no light filter. This one here is the 10% gray. So that's much softer. It's easier to then examine the back of the eye with, and that's the one that's recommended. The red-free filter, you can look at the retinal nerve fiber layer in a lot of detail with that. Equally, red looks black. That's the whole point of why it's called red-free. And if you twizzle the little round thing at the top, then you get the cobalt blue for use with fluorescein. So adjust the IPD, set your prescription right, get the patient comfortable, you're comfortable, align the medial canthus to that black bar on the side, and make sure that you start with a low magnification to get your orientation, and then a low light to keep them comfortable. So undilated fundus examinations are possible with a slit lamp, as many of you know. The number one tip is to use a very thin beam and shine it directly into the pupil, and then get the patient to look at your ear. And then at that point, you place the lens directly over their eye. And now watch my hand down there. I slowly pull back until I get a view of the back of the eye. And I've not gone all the way back, but I've gone far enough back that now that I'm in focus, all I need to do is go left and right. I don't need to go back and forward anymore. My lens is dead still, and the joystick is doing all the movement. So looking at the anterior vitreous is a useful thing to do, because you'll be in a situation in many medical retina clinics where there could be vitreous hemorrhage, there could be retinal tears and breaks, and complications of injections. You get the patient to look up, look down, and straight ahead. So this is a much better video, actually showing a Schaefer's sign of what happens if you agitate the vitreous by getting the patient to move and their eyes in different directions. And you can see these retinal pigment epithelial cells that are collected in that anterior vitreous. So dilated, it's much easier to then look at the back of the eye. Once again, you find the red reflex. It doesn't look red on this, but through the oculus it does. You then put the lens up, and then you pull the slit lamp back until you get a view, and then you can start moving left and right. So when you look through one of these lenses, everything is upside down. So it means when I get the patient to look up, the bottom bit of the lens is the top bit of the retina. So that's the more peripheral bit. And same again, if I get them to look to the left, the left bit of the lens is the peripheral retina. And then down and right. So as you saw in that video, there is quite a lot of glare that can happen as a result of the lens, the light being too bright or too open. And a way to overcome this is using this function here, which you can completely tilt the whole column of the slit lamp. You see that there? The other way, rather than tilting the column, you can just put the slit lamp to the side. Both of these methods mean that you can also look at the vitreous attachment to the retina if you're looking back posteriorly. So I'll show you this in real time. So if you tilt the machine, and then you can see that you can get a view. And the moment I tilt back the machine into its regular orientation, like now, you see how there's more glare, because the light becomes bouncing off that lens. Equally though, if I then turn the slit column to the side, there's far less glare, so the light's no longer bouncing directly back into your view. Fine, so these are the contact lenses, sorry, the non-contact fundus lenses that you need to know about, because it's very important you have an understanding that what lens you pick up does determine the magnification of the retina and the field of view that you're able to get. So the lower the number, the higher the magnification. So direct fundoscopy has no number, it's 0, and that's why it's the biggest. And a 90 has a much smaller magnification, and a 60 has a bigger one. Some lenses have had this extra curve, like the Super 66 and the Super Field, added onto the side to try and get a best of both worlds. But it's important that you know these figures whilst you're practicing. So this is a comparison of each of the different kinds of lenses. There's the Super 66, 78, and a 90. So the 90 is smaller than the 66. And this is a super vitreo fundus lens, which has a really wide field of view. So if you're looking for non-contact lens to look at a really peripheral retinal tear, break, or detachment, then this is the lens of choice if you find it in clinic. So, but if you really do want to go very peripheral, so say, for example, you're doing some laser treatment or PRP that you need to laser the peripheral retina, or you need a magnified view so you can really pick off individual aneurysms, then you can use a fundus contact lens. So you use some coupling fluid, anesthetic, and you pop the lens on, and these are the values of the common lenses that we use. So this is a SuperQuad 160. Guess how many degrees it goes out to? 160. So it's got a very, very wide field of view, 180 being the maximum. So 160 is done very, very well. You can also go all the way to the periphery using a 3-mirror Goldman lens, and using the lens, you can see that the smallest lens goes to the most peripheral. That's lens number 1 here. Lens number 2 is less peripheral, and lens number 3 is the most posterior. Make sure you decontaminate them effectively. So don't let them dry after you've used, and clean with the detergent or liquid soap for at least 20 seconds, and then rinse them with sterile water, and then dry with a non-lint tissue. This is part of your curriculum, so it's definitely worthwhile knowing. So the field of view, as we spoke about, are as follows with these different lenses. So you get a higher field of view with the 90 diopter, the contact lens, the non-contact lenses at the bottom, and the quadraspheric gives you a very big field of view as well. So indirect fundoscopy. Let's talk about this. We've got a few more minutes. Using the indirect ophthalmoscope is very useful, particularly in patients who can't mobilize onto the slit lamp, ward patients, and patients you really need to have a good look at the peripheral retina. So anybody who's ever had retinal tears or breaks, you can even do laser using an indirect, a laser indirect ophthalmoscope. So it's a very important skill for any ophthalmologist to have. It gives you a very wide field of view. It is in 3D as well, and you have one hand free to manipulate the eye. But usually to get right to the periphery, the pupil has to be dilated. Once again, the lower the number, the bigger the magnification. So 20 diopter gives you a 3-time magnification, but a less of a field of view, and a 28 gives you 2 times, but more of a field of view. And so worthwhile knowing these figures. Very useful tip for any practitioner is draw what you see. Just turn the paper upside down to 180 degrees and just draw what you see. And then you don't have to flip things around in your brain, because all the images from the slit lamp examination and the indirect are inverted. So these are the values, once again, in terms of field of view, magnification, and then if you're ever going to do any laser with these, then that's worthwhile knowing in terms of the magnification of the spot size. Fine, so patient needs to be well dilated, looking straight at the ceiling. You have the lens in your hand and your paper ready, and you adjust the indirect to your head. I'll show this in a moment to you. Adjust the illumination so it's nice and comfortable. You don't really, in a dark room, you can have a minimal illumination, particularly in children, if you're trying to look at the back of their eyes. And you can rest your hand gently against the patient's face to just steady that lens at the right working distance. So these are the eyepieces, and you can adjust these by sliding the plastic at the bottom so that it fits your pupillary distance, and you stick your thumb out so that it's in the center of that image, and you can also adjust the vertical height of that using the indirect. So this is me adjusting the indirect. I close one eye, I look at my thumb, and then close the other eye, I look at my other thumb to make sure that I can see the circle right in the center of where my thumb is, and then I'm ready to go. So the number one rule in indirect fundoscopy is make sure you have a red reflex, because your head can be moving a bit initially to begin with. You'll lose your red reflex. So always go from the start, find your red reflex, then put the lens over it, and then you can magnify in order to get the view that you need to. And if you ever lose it at any point, find the red reflex, put the lens over it, and then you can magnify. They say you need about 100 hours of experience before you're completely fluent in doing this. So the more training, hands-on training you get, the better you'll become, and it becomes second nature very quickly. So that was the 20 diopter lens. The 30 diopter lens, you do have less magnification, but a wider field of view, like we spoke about from before. So indented indirect fundoscopy, yeah, this is where these 100 hours are coming into, because there's several things that need to be still. Number one, your head, looking at that red reflex, making sure that the poor patient in front of you is still paying attention and with you. I normally put a drop of anesthetic on board, even if I'm indenting on the eyelid. So I'll try keep them as comfortable as possible. Ask them to look in the opposite direction initially. So if I want to indent inferiorly, I say look up. I put the cotton bud on, get the lens in place, and then I get them to look down. And then remember, even though the cotton bud's on over here, actually the indenter, because it's flipped around, this is what the indentation looks like. It took me about 6 months before I even saw my first indent. So it does take a bit of time, but that is what you're looking for. And so it's those little victories that will get you there in terms of persevering with this technique. Actually, all of those videos I did was just using a smartphone. So this is the technique. You turn your video mode on, light source on, 20 diopter lens, and because the flashlight is on, it's acting as a indirect ophthalmoscope. You can get a very good view. So just to finish, I just want to talk about how we code for or color in our drawing. So detached retina is universally blue, and a flat retina is red. And you can draw the retinal veins as blue, retinal breaks with a red with a blue outline. Retinal thinning is a hatching with a blue outline. Lattice is a blue hatching with a blue outline. And pigment is black, exudate is yellow, and vitreous opacities are green. Fine. So these are in summary, the kinds of conditions that you use separate lenses for. So the area centralis, the fundus contact lens, you use for diabetic maculopathy. For peripheral retinal tears, you can use a 3-mirror lens or an indented scleral examination. The transequator and the quadraspheric you can use for proliferative diabetic retinopathy if you're using laser. And for relatively anterior peripheral retinal tears, you can do these with a SuperQuad. So all of these, this whole talk actually has been recorded. So I've gone through this quite quickly. Number one, because I know the 30 people in here are very experienced, so I don't want to bore people, but at the same time, I've kept the content on here just so that anybody watching this in the future will have something they can reference back to. So those were the aims of the talk, and these are the things that we covered. And just want to thank you for my time, and I can't thank my partner enough for putting up with me and indenting her eye along with the eLearning for Health module to then get the rest of this material that you can do as per the OTCF curriculum. Thank you.
Absolutely fantastic, Krish. That was brilliant. I wish I had learned. I was training myself and could have learned these techniques better at the time. But it's again, the key point is to know your instrument, whatever the instrument you're going to use, slit lamp, indirect, and obviously practice. Keep practicing. Practice is the key here. I will open the floor now to questions for both Sherry and Krish, please. We got a good 6 minutes, so. Any questions, please? Just a quick introduction, where you work, and then fire away, please. Nothing is coming yet, but I'll just probably start with Sherry yourself. You did show a picture of the lacrimal gland. I think the picture actually depicted that the canaliculi were inserting separately into the lacrimal sac. Generally, we would see a common canaliculus.
Yes.
That might need to be
Yes.
sort of a look at that. But
Yes.
again, your topic was very broad. You know, it says it was covering from the front to the back of the eye, and it says a massive area to look into.
Yeah, no, that's correct. I think that needs a bit of correction.
Yeah, and the other thing is there's a lot of work going on now with the retina and the photo